overshadowed by more visible threats, is a slow-burning crisis that already causes over 1.27 million deaths per year, according to the WHO. Dr. Nivapur will guide us through collaborative clinical and policy strategies needed to curb this threat before its crisis cancer as the leading cause of death globally. Please join me to welcome Dr. Shashank.
Thank you. So, as the last speaker before the final session, glad to see at least a few people still awake and alert over here. So, we'll hope that the next 10 minutes that we have been given, we should make justice to what we are going to talk about. Very big thank you to the Fakeeh University Hospital for hosting us. Thank you to our leadership at CAHO, Dr. Laluma and Sam, for giving us this opportunity here, and all our wonderful panelists and our other expert speakers and participants here. So I'll start with the case history. As clinicians, we all love to start with case histories. I'll make it very quick. 40-year-old male patient, recent history of international travel, returned back to India with symptoms of URTI, sore throat, mild cough, runny cold, body ache. Since 4 days, no other major comorbidities. Examination, runny nose, tonsils swollen, mild grade fever, pulse 90, BP 120, 8/78. Next course of action, as clinicians here. Start antibiotic. Yeah? Should we? Or start supportive therapy with antibiotics? Just start supportive therapy, watch. Or get the whole scale, what Aparna ma'am spoke about. Get the full gamut of corporate examination possible packages that are there. Okay. So we'll hold on the answers. There are a lot of good clinicians here, so we'll wait for the end of it. So this is something I want all of you to ask yourselves, is that when is the last time you took an antibiotic? This is very important. How do you know, who prescribed it? I don't know in the UAE, I'm not sure. But do we have a prescription for the antibiotics that are required?
Yes.
Yeah? Okay. So we are at least glad that has happened over here. But in India, it's like the Wild West. So you can, just like in the US, you can buy a gun. In India, you can buy an antibiotic, the highest end possible without any prescription. So that's how we work over here. So the topic that I want to talk about is that AMR today is not a problem of just the growing countries. It's not a problem of the low and middle income group countries, but everywhere, because we are traveling all across. We just saw with the COVID pandemic how within a few months started from one part of the world and then spread all across without any kind of barrier to protect it. So unless we tackle this problem of MDROs, multi-drug resistant bacteria, with both proper infection prevention and control and proper antimicrobial stewardship, it is going to be a challenge for us as we go ahead. Now, I'm going to talk about two major papers. As I said, no conflicts of disclosure. Two major papers. This is the one that came out last month. I don't know if anybody had a chance to look at this in the Lancet publication. This is the WHO priority list of this thing. Unfortunately, today in the news we see other priority lists being shown across. Top 10 FBI most wanted, those are the ones. But I think as healthcare workers, these are the top 10 that we should be worried about. AMR pathogens are going to become the highest burden for healthcare costs coming up in the next 20 to 30 years. Currently, we say about 1.2 million deaths, and this would go as high as 5 million in 2021 is what the statistics tell us. But there are a few more scary statistics that you will see, not to put you scared about, but this is what we see. On the list of most wanted pathogens, suddenly you see CRE, Klebsiella pneumonia has grown up to become the #1 choice for that. And then, if you see here, Escherichia coli, Acinetobacter baumannii, rifampicin, resistant tuberculosis, which was not even present in 2017's last report, has suddenly become the top 5. And if you see here how the things have changed, Acinetobacter baumannii has actually come down, mycobacterium suddenly appeared all over, and Klebsiella pneumonia has become a big part, the #1 reason that causes the highest amount of mortality. Now, I don't know whether you have noticed that this also coincides with the introduction of orally available carbapenem called ferropenem, which has been heavily marketed in the last 8 to 10 years, right? So, is this a coincidence or this is actually what is happening? Improper, immoral marketing of antibiotics has led to overuse of antibiotics and AMR that's going on increasing. But what is the problem that we see with this? global trends, as you said, AMR reports are increasing. Now we are going to a point where we don't have sufficient antibiotics, especially in the low middle income countries, to treat with gram-negative bacilli and gram-negative bacteria. While in the Middle East, the situation is sort of stabilized, but it's still a growing concern that we see. And if you see the causes of concern is overuse, misuse, and improper use of antibiotics, overprescription, self-medication. Many of us as doctors sometimes pop in antibiotics thinking that these are, tic-tac-toes, we just have tic-tacs over here. So this is something that we look at. Poor infection prevention. One of the biggest things that we see in LMIC countries is poor sanitation. So that's the reason WHO still focuses more on the wash and stools that are required. Agriculture and environmental factors, some of which are not in our hand, but we have to include it as a part of the One Health strategy that is there. And then contaminated water sources and pharmaceutical waste that is there. Coming back to another report in 2024, this was September 24, they say in 2050, the major reason for healthcare deaths is not going to be heart disease, it's not going to be the cancer, it is going to be antimicrobial resistant bacteria that are causing these deaths. And when you look at these deaths, it is not just associated deaths, but these are attributable deaths. And look at the age group that it's affecting, the 45 to the age group of 70 or 80. That means all of those who are now in the 40s, in the next 30 to 40 years, things are looking really grim for us. So if you accidentally get admitted into the ICU, things are not really great for us. Right? There will be not many antibiotics that will work for us. And this is a person who has worked in the industry, looked at pharmaceuticals. We know some of the pipeline what is available for us, and things don't really look very promising. But one of the two good things that have happened post 2017 after the WHO priority list, a lot of companies have been started focusing on gram-negative bacilli, and research has been happening, but it is not to the extent at which the resistance is developing. Remember, the bacteria will always grow smarter and become more resistant more faster than that. So, concern if you see the map in 1990, most of these antimicrobial resistance was largely in sub-Saharan Africa. Then it started becoming a little more worse in India. Now, if you look at this report, Argentina, Greece, India have become big causes of concern. So if you see here, obviously in the Middle East, the number of deaths that we have attributed for every 100,000 things are much lesser. But in India, this is a big concern for us, because one of the major reasons for us going ahead in the ICU, for patients who are admitted in the ICU, AMR is going to be a big problem for us, multi-drug resistant bacteria. So, question is, how do we get across this solution, right? Yes, One Health is a concept that not many people of us understand, because the reason is we as physicians and clinicians, we don't even agree with our ICN saying that we need to do a better hand hygiene. And as physicians, we are the worst when it comes to hand hygiene. We have to accept the fact. Housekeeping does in fact a better job of hand hygiene than there. And One Health approach is something that WHO and CDC have been pushing. So this is a requirement where it is not just at hospitals as individuals, but even at the government level, at a national level, and international level, this is required to be done. So antimicrobial stewardship programs, I know I started this in 2009. It's still been a journey, and it is a journey that I plan to continue for the next how many years. We are not going to be infected by any multi-drug organism. So proper antibiotic stewardship is very important. Antibiotic stewardship, whether you're choosing an antibiotic or an antifungal or an antiviral, it is very important. And that has to be clubbed with proper infection prevention guidelines. It does not work. Most of our physicians and surgeons, when it comes to use of antibiotics, I'm sorry to say this, but it's more of a spray and pray therapy. Give everything that is possible that is there and cover every possible organism. But luckily, thanks to people like Dr. Aparna, they've been getting better faster diagnostic reports. We get that. Thanks to people like Natalie, we started getting better surveillance reports, so we're doing much better than that. But this is something that we have to look at as we go ahead. There have been a good number of case studies from the Middle East. I think one of the great things that the UAE has done in the last 10 years is to put a control on the amount of antibiotic prescriptions and how they are being dispensed. India has started this. I know on paper a lot of things are there in India, but I can say at least the state of Kerala has made a big progress, because they were one of the the first states to start antimicrobial stewardship in the private sector and then move into the government sector. Question is, any guesses? What's happening over here? I'm sure we come to the end of the day, so all of us would love to have a good drink. Right? A mixologist does a great cocktail for us, takes away our pain, but unfortunately, our surgeons and physicians do a great cocktail, it doesn't really work for us. So unless we understand proper PK/PD parameters, look at the clinical scenario of patients, unfortunately we have to go back to learning some of our basic pharmacology for the right drug, for the right dose, for the right duration. This will not work. So that's the reason why, as physicians, we need to go back to some of our basics and understand proper PK/PD parameters before we choose the next antibiotics. So, what is the future of infection prevention? We have antimicrobial coated surfaces which look promising. We have done a lot of work around that. Antimicrobial textiles which can actually have your scrub suits using silver nanoparticles which can actually repel bacteria, multi-resistant bacteria, curtains, bed sheets, all of these. Smart hand hygiene systems, I'm sure somebody is going to be speaking about this. Ultraviolet light, always a little controversial, but still can be a new choice for looking at surfaces. And better point of care devices which look at infection prevention, surveillance strategies. I'm very shamelessly borrowed this from MedPlay, so for Dr. Arun, apologies for using this, but we use it, so we are happy to share about this. So yeah. So a take-home message that I would say, AMR is a global crisis, coordinated efforts are required, healthcare professionals, integration is very, very important, nurses, doctors, engineers, everyone coming together. Local policies and international collaboration is very much required. And important is to act now, not to wait later. And as Robert Downey Jr. said long back, Avengers have to implement. Thank you so much.
Thank you, Dr. Shashank, for the impressive presentation. With this staggering figure, by 2050, we're expecting 10 million. That is, hopefully, it's not the case.